Um,
What's the microphone? Am I is it?
Microphone, you don't need the microphone, but
Okay,
because you're being listened to from there.
Okay,
Okay.
that's fine.
Welcome everyone to the last talk. Thanks for sticking through the whole workshop. I hope you've enjoyed it. And we're delighted that our last talk was given by our own David Papineau on causal inference, structural equations, and patient-centered care.
Thank you very much. Thank you for having me. It's been a terrific workshop. I'll say something more about that at the end. So here's my plan. I'm going to say something about clinical research, about what kind of findings it gives us, and then I'm going to do some stuff about the metaphysical nature of causation, and so that'll be probabilistic theories of causation and structural equations, and then I'll say something about medical practice again, and end up with argument for the ineliminability of medical judgment about particular patients. So there's some medical practice and some metaphysics. So let's just take the typical case. We do a randomized trial, or perhaps we do a retrospective observation survey, and we get causal judgments. This treatment causes recovery. Actually, we get something about the effect size. This agent causes illness. Okay, there's various standard issues raised about such findings. One, stressed especially by Nancy, is external validity. What's the kind of setup where we can expect these findings to hold good? Maybe we have to assume that we're in a certain kind of social structure, that Nancy's example last night, the tax system works, the manufacturers have to pay their taxes, and so on. We just hold that fixed. And ideally, we'd like that to be made explicit, and we'd like data to be a representative sample of cases from that kind of background. I'm not going to say very much about that issue of external validity. I will come back to it in a sense at the end. Another issue is the problem of confounders. We were talking a bit about that in the last talk. If we find, either in our trial or in a survey, that the R for recovery rate varies with T possible causes of R, is it because of T, or is it because T is associated with other real causes of R? And this kind of worry can be addressed in different ways. Randomized trials address it forcibly by decorrelating T from the other causes of R, and surveys try and include all the possible confounders in the analysis. And then you apply, as I was talking about, with standard techniques for inferring causal conclusions from observational data. And standard techniques, they hinge on two assumptions. I'll mention that because I'm going to come back to that later. One assumption allows you to go from correlations to a causal conclusion. It's the common cause principle. If you have a correlation, either A is causing B or B is causing A, or they have a common cause. And if they have a common cause, the correlation will disappear and you hold the common cause fixed. It's the common cause principle. And the faithfulness condition is the converse one. If you find a non-correlation, that's because A and B aren't causally connected in that way. Either one causing the other, or they have a common cause. Some of those things hold if you find a non-correlation. That's the effect. So you can infer causal structure from correlations and absence of causal structure from non-correlations. I'm not really interested in forming confounders, but I'll come back to these Bayesian network assumptions in passing later. The issue I want to address is, in a way, third issue, and it's more basic. And put it like this: the findings of medical studies are always probabilistic. We find out that the probability of recovery given a treatment is such and such, probability of recovery without the treatment, something different, maybe the average treatment effect. It's a probabilistic finding. Or if you've got quantities, it might be time of recovery, and you'll find the distribution changes depending on whether you're T or not T. Right. T itself might be the quantity, then we'll have a joint probability distribution, but the findings tend to be in the form of probability distributions. And you might worry, what's that got to do with causation? I mean, isn't a cause something that determines its effect? The causes, are something that make the effect inevitable. So, in what sense have we found out that smoking causes cancer, when in truth, only 5% of smokers get cancer, as opposed to 1% of non-smokers getting cancer, but we haven't found something that determines cancer? In what sense have we discovered a cause? We find some treatment produces some desired effect. Chemotherapy hits a certain kind of cancer. We've only discovered something probabilistic. In what sense is that discovering a cause? Okay, this is something that philosophers worry about. I mean, in a way, the medical practitioners can kind of shoot ahead, and a lot of what I say will kind of seem to you like common sense, but it's quite hard to articulate. And philosophers, in fact, often get into quite a muddle about this. And one kind of muddle is what you get with probabilistic theories of causation. So these go back to Reichenbach, Suppes in the 1970s, and in effect, they deny the implicit assumption I made a moment ago that causation is deterministic, that causation is a matter of the circumstances determining the result. They say, no, that's a mistake, that's a mistake. We should never have thought that. Quantum mechanics has shown us the world is not deterministic. We should think of causes themselves probabilistically. And you get a range of different versions of this approach. So Suppes originally said, one factor, I'm using TNR for treatment and recovery, but it's general pain. One factor causes another if, in fact, I've left it out. If the first factor causes the second factor, sorry, the first factor comes before the second factor, I left that out, and they're correlated, and nothing else even earlier screens off the correlation. So it's kind of basic first pass idea of the common cause principle. People now looking at the Bayesian network techniques, which are much more detailed and sophisticated, and in fact, I should mention, people know about common cause principle is a kind of first approximation to the thing you really use, which is the causal Markov condition, which is harder to understand, but kind of in the same ballpark. A number of people say, well, we've got these techniques that take us from probability distributions, apply the Bayesian network assumptions, you get causal conclusions. There's nothing more to causation than what was already implicit in the probabilities. Causal connections are just the connections that you infer from those correlations, and nothing over and above the specific pattern of correlations. Dan Hausman wrote a very nice book, Causal Asymmetry, about 20 years ago, and he has a rather neat explicit reduction in this spirit. And he doesn't have to assume time like Suppes did. It's very neat. He says, one variable causes another, in the sense, say, that smoking causes cancer. If and only if they're correlated, and everything correlated with the first one, think its effects and its causes are correlated with the second one, and something correlated with the second one, think its independent causes aren't correlated with the first one. And when you have that, then you know this is the cause and this is the effect. The idea is that the effects always have an independent source of variation, and that's kind of the idea that drives much of the Bayesian network inferences. I think of Jim Woodward's interventionist theory of causation very much in the same spirit, and he puts it kind of factually, and he's kind of thinking about the inference from a randomized trial, but he says T causes are if and only if they would be correlated if T were produced in some randomized way. Sometimes you get the impression that Woodward is talking about actions on human actions, but in fact, this notion of an intervention just means a variable produced in a randomized way. So here, people who just want to say that the question I asked, what do these probabilistic findings have to do with causation? Because causation is deterministic and they aren't. These people say, no, you're making a mistake. Causation isn't deterministic. It just is. Those kind of probabilistic correlations. I think that's a very bad idea. And it's surprising it has such currency. And there's all kinds of ways one can show that there must be something missing in that probabilistic account of causation. Here's one nice example. Here's those famous birth control pills, thromboses, P for pregnancy. Birth control pills, you take birth control pills, it prevents pregnancy and it causes thrombosis. But pregnancies also cause thrombosis. And you could see that the two paths could kind of cancel out in such a way that birth control pills and thromboses were not correlated. You had just as many thromboses among the women who took birth control pills as among the ones who don't, because even though the birth control pills are causing thrombosis, they're preventing the pregnancies that causes thrombosis. And so there'd be a case where birth control pills do cause thrombosis, but there's no correlation. So the idea that causation just is correlation, taking into account confounders, is a mistake. You might wonder, do birth control pills really cause thrombosis in Hislop's case? I mean, this is the feat of imagine that you're a woman who was concerned only about thrombosis and nothing else. You didn't care whether you got pregnant or not. Right? You're only concerned about producing or preventing thrombosis. You'd have no reason to worry about taking birth control pills because it's going to make no difference with thrombosis. You might think, in this case, birth control pills don't cause thrombosis. But no, despite that thought, there could be a particular person who takes a birth control pill, doesn't get pregnant, but gets a thrombosis because of the effect of the birth control pill. So you could have a particular case with the birth control pill causing thrombosis, despite the non-correlation. And in fact, if you start thinking about the connection between the generic claims like smoking causes cancer and particular cases, you start to see there must be more to causation than the generic case. I mean, think about it the other way around. There's a probabilistic association between smoking and cancer, all right? But you can have a particular person, and it's not due to any confounder, but you can have a particular person who smoked and got cancer, yet their cancer not be caused by their smoking. I mean, maybe their immune system stopped the smoking causing cancer, but they were exposed to asbestos and that was causing cancer. So there's more structure to causation than you get out of the generic probabilistic claims like smoking caused cancer, or chemotherapy causes cancer. So here's what I want to think is the substance of causation. Nancy was talking about this a bit last night, structural equations. We want to think of real causation, kind of bottom level causation, in terms of structural equations. So people who've done statistics would have seen this kind of thing, but what example did I have? So let's suppose, for the sake of the argument, yes, birth control pills come in degrees, thrombosis maybe come in degrees, pregnancy doesn't come in degrees. But put that to one side, and you might think, look, when you take birth control pills, depends on a bunch of background factors. Whether you get pregnant depends on the birth control pills and some other background factors, and whether you get a thrombosis is a function both of whether you're pregnant and whether you take birth control pills and some further factors. So we suppose that kind of underneath the generic probabilistic generalizations are some more fine-grained deterministic generalizations that explain how the dependent variables, the effects, are determined by the independent variables, plus some extra noise terms, all the other factors that make a difference to whether my smoking determines that I get cancer. Once we've got these more fine-grained deterministic dependencies, then we can see how to think about single case causation. A particular value of X, my smoking, is a single case cause of a particular value of Y, my getting cancer. If the smoking, together with the other values, the actual values of the other relevant factors, determine me to get cancer. And this is a familiar idea. It goes back to Mackey's account of causation in terms of Inus conditions. It's kind of implicit in Judea-Pearl's interventionist semantics for counterfactuals. It's the kind of thing that people worrying about actual causation, which is a slightly different version of single case causation than counterfactual dependency, they appeal to structural equations as well. So it's these fine-grained dependencies that tell you what's going on in the single case. And once you've brought these more fine-grained dependencies in, you can see the generic claims, smoking causes cancer, as partial information about the relevant system of structural equations. That in the system of structural equations, smoking is an equational ancestor of cancer. And you can see the correlation of data with which we start as evidence that smoking must be an ancestor of cancer. And what's more, you can see the quantitative aspects of the correlational relations, the average effect numbers, as telling you how often, on average, you will find smoking operating as a sufficient condition of cancer. So the idea is, at bottom we have the structural equations. The generic claims are kind of summary statements about the structure of the structural equations, and the correlations are kind of information about how often the variables in the structural equations operate. So this is very much in line with evidential pluralism. The picture is we have the statistical findings, we have I'm not calling it mechanistic story, but that's what the structural equations are. And we have two ways of finding out about what's going on in the structural equations, maybe directly by detailed biochemical research, or indirectly by looking at the generic claims. You might wonder why believe that there are these structural equations? I mean, I kind of pulled them out of nowhere. That down there's all these deterministic dependencies between the variables we're interested in. I think it's inference to the best explanation. I've just shown you how they give you a nice way of understanding what's going on in the single cases. I think they're also necessary to explain why we can infer generic causal claims from the correlational data in the way we can. When people do Bayesian network inferences, they assume these principles, the common cause principle, the faithfulness condition, and they churn away and they pull out conclusions about smoking causes cancer, etc., from the correlations. But you might wonder, what's the basis for those Bayesian network assumptions? And the structural equations picture allows you to explain that. With the help of a little additional assumption, if you assume that the noise variables are all probabilistically independent, then and I won't go through it, the common cause principle follows. Take any two variables, they'll ultimately descend. Any variable will ultimately descend from some collection of error terms. Take two variables. If they descend from independent, disjoint connections of error terms, they'll be probabilistically independent. So if they aren't probabilistic independent, they must somehow either one be descending from the other or have a common ancestor, and that's the common cause principle. Faithfulness condition. it's the other way around. If two variables aren't correlated, well, that's either because they don't have a common ancestor, or because there's freaky cancelling out, as in the Heslow case. So you can assume that absent freaky cancelling out, the faithfulness condition will hold, and you can infer from absence of correlation, absence of causation. But the faithfulness condition, unlike the common cause principle, is a fallible rule of thumb. So all that comes out nicely if you assume the structural equation story. So that's what I just said. You might be worrying about determinism. I'm assuming determinism now. Quantum mechanics, I said, gave us reason not to be deterministic. Yeah, maybe we should worry about that. But even if that's true, I think it's pretty obvious that causation involves many fine-grained dependencies that are averaged over when we say smoking causes cancer. Different people will have different chances of cancer when they smoke, depending on all kinds of factors, including the immune system, the rest of the environment, and so on. And if there's a bit of chance of causation in there, it doesn't matter too much, in fact, and it won't block the derivation of the basic network principles, provided we make a few small other assumptions. So while the assumption of determinism might be accurate, it doesn't really matter for the analysis I give. So in the interest of simplicity, I'll go on assuming. In fact, everything I'll say will go pretty much through the same, even if we don't think everything is deterministic. Okay, enough metaphysics, back to medical practice. And we've now got a different puzzle from the one I raised by saying, isn't causation deterministic? So what are these probabilistic generalizations got to do with it? And I said, causation is deterministic. There's a lot more fine-grained detail in the probabilistic generalizations. But now it's a different problem. So smoking causes cancer, but not in everyone. Chemotherapy halts the cancer, but not in everyone. That's why it just raises the probability of recovery. It doesn't determine recovery. And so you might now start wondering, well, why should I stop smoking just because on average the chance of cancer goes up, given that I might well be the kind of person in whom smoking is not going to make any difference? I've got no reason to stop smoking in that case. Similarly, should I have the cancer treatment, given that it's quite possible, that despite the early signs I've got, I'm not going to die of cancer? Why would I have the treatment if I'm that kind of person? And is this a real worry? Well, for many people, it is. This is the issue of overdiagnosis. And just to show that I'm not making up a straw story, here's an article from The Guardian. Just a year ago, woman had a mastectomy. She had an early diagnosis of incipient cancer. She said to the doctor, well, thank goodness, I'd probably be dead. I'd be dead by now. And he said, well, no, probably not. Because only 10% of people like you go on to die. And as the journalist tells the story, this was a terrible thing. Screening detects lumps that going to cause harm, mastectomies, over-treatment, psychological stuff. Okay, that's The Guardian. But not a joke. Here's Cancer UK. Overdiagnosis is diagnosing a cancer that wouldn't have gone on to cause harm. You hadn't been screened, you would have lived on a happy life, never known there was an issue. And here's Cancer UK going on yet further. Well, we can't always tell who's going to die and who's not. Some people will go through treatment when they didn't need to. It's important that people are aware of overdiagnosis as the possible harm of screening. Now, I actually think this is all misconceived. The worry being raised here is not a serious worry. Let me put 2 points to one side. One issue is that you do some screening, you get an initial sign of cancer. Standardly, it would be crazy to engage in radical treatment, radical surgery at that point. Why not get more information about whether the cancer is bad? And of course, that's standardly what happens. And this is a general point that putting costs to one side, getting more information before making a decision is always going to be better. There's a more subtle but serious point that however much information you've got, there's a tendency, well, there are cases in which people tend to opt for a radical treatment with appreciable downsides, even when the expected value is not positive, because of the stress of waiting to see if the cancer develops. So many men who are diagnosed with prostate cancer immediately want medical surgery, but if you look at the expectation of harmful side effects, the increased chance of survival, it wouldn't be a rational decision for them to make. But knowing that you've got a possible cancer growing inside you makes many people have an operation, and it's a serious issue. And in fact, roughly that's why we don't have a prostate cancer screening program in this country. The thought is that it will create strain that makes people have radical treatments that wouldn't otherwise be worth it. But if you put those 2 points to one side, the mere possibility that the treatment might be unnecessary in your particular case is no argument against the screening or undergoing the treatment when you get the diagnosis. The expected value of the treatment might be far greater than the expected value of doing nothing. And the fact that it might be needed in your particular case doesn't alter that point. I mean, it's a kind of standard problem in thinking about probabilities. I tossed 2 coins and I had them under my hand, right? And I say you can choose one of two things. You can say there's 2 heads under my hand, or you can say there's fewer than 2 heads under my hand. The first happens 1/4 of the time, the second happens 3/4 of the time. Of course, you should say fewer than 2 heads. And look, it might be that there's 2 heads under my hand, and that post hoc, you might think, oh, I wish I'd said fewer, but I wish I'd said 2 heads. But that doesn't mean it would have been rational before you knew the result to say 2 heads. The fact that you might be making the wrong choice is no argument against. You might be making the wrong choice post hoc. There's no argument against betting with the odds X and Y. So people should, in plenty of cases, have treatments with downsides because the expected cost on the other side is greater. So it's kind of deep in the human condition that we have to choose in ignorance of all the details of our particular situation. We have to act on the probabilities. The probability of recovery given treatment, there's probability of recovery given not treatment. You can think of those as the probabilities that the recovery will be determined in your particular situation with or without T. And that comparison tells you whether it's worth doing the treatment, how much reason you have to do T in pursuit of R. And that's what medical surveys and trials give us. The probability of recovery given chemotherapy, various treatments giving rise to various recoveries. Okay, I promised to give you something about patient-centered care, and you might be wondering, where's that coming? So far, this just sounds like a story of evidence-based medicine. Look at the surveys, look at the trials, write out the guidelines. Doctors should follow that. Well, I mean, clearly nothing I've said argues against taking the patient's particular values into account. I think different patients might care more about the downsides of the treatment, or more about the accelerated recovery. And of course, doctors should take that into account in deciding on advising treatments. And I've said nothing to bear on that. But in fact, if you probe a bit harder, my analysis supports a much more basic reason for thinking about treatment in a patient-centered way. So suppose that we're sure about how much the treatment will raise the probability of recovery in, say, and now we've got a definite reference class, 40-year-old men, Scandinavian heritage, in a given social context, Nancy's social monological machine, and we've got such a patient behind us. Okay. But suppose in addition we know some more things about the patient. We know the patient smokes 40 a day, is overweight, has heart fibrillations, and suppose that we don't have any survey data or randomized trial data, or even survey data about the probability of recovery given the treatment and all those things in addition to the reference class in the data. Now, one thought is we got no data. Stick to the guidelines. Ignore these extra facts. Long ago in the philosophy of statistics, people used to worry about direct reference. What probability should you assign to the outcome when you're making a decision? And they'd say, use the frequency in the narrowest reference class for which you have good evidence. That would say, stick to the guidelines. Ignore these extra facts you know about the patient. You don't know anything about how relevant they are. I think that's wrong. In effect, if you ignore the extra facts, you're supposing they're probabilistically irrelevant. You're supposing they make no difference to the chance of recovery given the treatment. But common sense, or even better, medical judgment, informed medical judgment, will often tell us that's just mistaken. Of course, these extra facts make a difference to the probabilities. I mean, we're doing the thing with the coin again. Suppose you know in addition that coin's just landed heads 10 times in a row. Could you say, look, I don't have any statistics about how often coins land 10 times in a row turn out to be biased? I should just ignore that. Suppose you can see the coin is bent. I don't have any statistics about how often bent coins turn down heads. I mean, clearly there's some reason to think that the chance of 2 heads has changed given this extra information. So in truth, we can't avoid making an estimate of the objective probability in the reference class defined by everything we know about the patient. So that's my opinion. Once we probably understand the structure of causation, medical judgment about particular cases is never going to be eliminable. The medical professionals always have extra information, put the patient in a narrower reference class than those used for the studies behind the guidelines. I mean, often it would be sensible to say, they've got red hair, well, that's not going to make any difference. But in other cases, it would be clear that extra information does make a difference to the probabilities. And whether or not it makes a difference, you're going to need medical judgment about particular cases in order to decide on treatments. And that's all I've got to say.
Wonderful questions. Got time here, but quick. I'll try and be fairer this time.
Just to slightly push back on that last point, as a clinician, I think that our intuition about how much insight we have into these things is probably suspect, and that as far as I'm aware of it, that the most of the empirical data supports a greater coherence to guidelines, gives better outcomes and more individualistic treatment. Well, this patient's not exactly like that, so I'm going to play around with here and mess around with the recipe a little bit here and there. actually gives rise to worse outcomes overall. I mean, it's a temptation. Obviously, the more information is better. Which again, pushing back to that other side, I think that more information is not always better, because sometimes it makes decisions a lot harder and it pushes us down different paths, and particularly it causes a lot of anxiety for patients and families if we don't know what to do with the information that we've got. And we're seeing it at this moment in genomic studies. We're generating a huge amount of information we don't quite know what to do with. And there's many other contexts we're trying to find this, including screening data.
So, of course, I agree that I'm saying that clinicians are going to, at some point, have to rely on their intuitions, their kind of not probably evidence assumptions. And it would clearly be better if there was evidence available to either back up or undermine those intuitions. I mean, of course, more research is better. You said that there's evidence that outcomes are better if the clinicians follow guidelines than if they use their judgment. As it happens, I had a fantastic student about 5-8 years ago, Luis Flores. Does anybody remember? I mean, who's now working as a psychiatrist in Santiago again. He did a full-on meta-analysis of outcomes for treatments and diagnoses, comparing not guidelines and unadored judgment, but guidelines and guidelines plus judgment. And he said his meta-analysis showed that these were much better. And all the meta-analyses that purport to show the opposite are no good. Final point, look, there's going to be some cases where it's just obvious what I'm saying is right. I mean, if you have a child whose whole family is allergic to penicillin, and I've got no data on whether a child whose relations allergic to penicillin is themselves going to get allergic to penicillin. I'm just going to ignore that fact because I've got no data. It'll be clearly wrong. I mean, there's going to be cases like that. And okay, I'll stop.
I think there's a finger on this point.
Yeah, so I think we have to distinguish, we can accept the principle of total evidence
Good.
And still wonder what exactly you're talking about when you're talking about quote unquote medical judgment, right? Because some of the kind of worries are that when you step outside of the guidelines, which are based on these kind of populational, correlational, statistical data, you are allowing biased judgment to come in. And that's why in a lot of the studies which compare individual judgments with very basic like statistical models, the models in the long run have better outcomes because there are all of these biases that come in.
I deny that. I mean, that's what Lewis looked at very carefully.
I know, but that's one meta-analysis, and like I think there's multiple kind of like there's so much evidence to show that actually like individualized judgment is highly biased.
No, of course, but nobody's saying ignore the guidelines. That would be
correct.
Crazy.
Nobody is saying the principle of total evidence is not true.
I've got one more. I spent some time before this talk looking at guidelines, and to be fair, the nice guidelines tend to be pretty damn detailed. I mean, they go into contraindicators and treatments for different ages and so on. So, but still, I say, after you've been through all that, there's going to be some extra information you had, and you can't just take it as given that it's not going to be probabilistically relevant. That would be a weird thing to do. Yeah. Well, always assuming it's irrelevant is one kind of bias, and that's a very strong and definite bias. And I'm against that bias. I mean, other biases might be bad too, but probably not as bad as that one.
Yeah, thanks very much, David. I kind of had, well, that's both questions. One question is just, yeah, do we really need your very interesting analysis of the underlying causes to get at the final point? I had the kind of feeling you could get at the final point that we just had this argument about much more directly. That was one question. And secondly, on the discussion we just had, I mean, I had similar concerns about clinical judgment. And I think, I mean, your response in a way is very good, right? Because it says, no, of course you need to do all the guidelines. And then it's only with the extra bit of remaining information, right? Where you ought to narrow down your reference class even further, but you don't have the relevant information. But of course, one thing that we need to also build in medicine is that people are fallible. Doctors in particular are both fallible and quite immune to consideration of their own fallibility. So, you know, the concern about, of course, the clinical judgment is not just a concern about bias, but it's also a concern that, say, if you give, I mean, it's going to sound a bit cynical, but, you know, if a doctor goes to your talk and they, David Papineau tells me I'm going to listen to my judgment, they will then make the mistake of not doing all the guidelines first and then appropriately reserving their discretion just for that final bit, but rather go back to going with discretion much too soon in the process. And, you know, that's maybe, I mean, that's a further thing, I guess, that people who study clinical judgment and write the guidelines have concerns about.
I'm surprised I'm getting all this pushback. Look, I certainly don't want to go back to the bad old days before anybody was concerned about evidence and didn't try and do trials and so on. But I'm surprised to find people saying, really, you ought to stick to the guidelines and not use extra information to tell you that they're defining this case. Now, I can see people would do stupid things. I mean, if they thought this was carte blanche, right? But as I said, there's going to be some obvious cases where you've got a 35-year-old person who's prime candidate for the chemotherapy, but you can see they're really frail, right? They're just not going to stand up to it. I mean, do the guidelines say something about that? Well, perhaps not. I mean, that maybe. I think there's. Yeah, no, I was just thinking that I was just thinking that's probably not a good case, but I'm sure I could make up cases where we find something that you don't have to be a crazy idiot. Any sensible person would think, oh no, the guidelines are telling me the wrong thing here, and I'm sure everybody would agree. So I'm just making what I take to be a pretty obvious one. About the other thing. In order to make the points, you do need to see that below the generic claims that in this population we have this average effect, there's going to be more specific facts about how things go for different people. You need that much in order to make the general point I was making. Maybe it doesn't have to be worked out in exactly the way I did, but you have to see that there's more fine grain. The reference classes that we're working with are not homogeneous. That's the basic.
I think there are a million fingers on this point, but maybe we go to a different question just for the sake of diversity in questions.
My question can be considered a finger, but sorry about that. But anyways, I just want to follow up on this previous point that you just considered. Again, my question is how the structure of that's underlying probability, even if it is the case, will inform the next part. Because if I want to basically work from the end of the talk to the beginning of it, I would say that what really matters are the probabilities, and the specific cases that you correctly point out that are important could be put in the conditionals, on the conditions in the conditional probability. And so no matter what the underlying structure of the causation is, what really matters at the end of the day is what you described by tossing the coins, basically changing the probability. So maybe we can just, although it is correct that there is underlying structural causes, but maybe it is not really important for making the case in the second part of the talk.
So I agree that on my view, from a God's eye, so you can put everybody into an actually narrow reference in which the probability of the problem is without maybe when you get to the narrow, the modular reference path, you could probably work with it, and that's how the reference in determining. But I think in practice, we're never going to get to those modular reference. We'll be already be averaging over different so we're always going to make them work. And if you want to find value of things, and then you have to instant how you can do the more.
Thanks, David. Yeah, so just focusing more on this patient-centered bit, but not with the values thing, but just, you know. So, yeah, there's this big problem with medicine, which is that all of our evidence about causation is statistical, it's probabilistic. You can stratify, you know, keep going down into sort of learning more things and stratifying, and this is so-called personalized medicine. But personalized medicine for a person or a patient isn't like that, really. People want to know, they want to consider themselves deterministically. They want to know whether an intervention is working for them, not whether they're an average. And so I wondered, you know, is there, in your interest with fine-grained dependencies, I'm talking about this, something that, you know, doctors can learn, which is doing more than just using their clinical intuition. I think doctors are doing this all the time. Their comments, I mean, they're negotiating fine-grained dependencies all the time. And so the question, I guess, is there a sort of toolkit, you know, a bit like Nancy's thing yesterday, which could be deployed here to, I mean, the obvious one is you start a medication because NICE guidelines tells you to. And thereafter, you don't really know whether or not that medication is having an effect unless you stop it and see what happens.
Yeah, well, that's an issue about how we adjust the treatment in the course. But on the more general issue, look, so the patients like to think of themselves as a kind of unique reference class defined by all the facts about them, and the outcome is determined. And then there's the reference class in the guidelines, which will be quite coarse, and we can put patients into that. And the trouble with the first reference class is we're never going to know it. So, sorry, patients, but you're basically in a situation of making a bet with a gambling machine, and you've got to think of it in that way. My view about the reference class defined by the guidelines is that it's unreasonably coarse, and we can see in some cases that we've got a patient in front of us where we judge the odds are different from the average person from the reference class in the guidelines. So that's how you have to use this reference class, the one defined by everything you know about the patient. I mean, lots of what you know about the patient is clearly not going to be relevant. I mean, you know, they're wearing a blue shirt and so on. But some of the things might well strike you reasonably as relevant, and then you should take that into account. But no, there's no magic panacea. These are difficult things. Has Constantine got a question?
Yes, and so does Barbara. Do you want to go up to Constantine and then Barbara?
You're in charge.
I'm in charge. Well, actually, yeah, I'm in charge. Listen to me. Barbara, are you able to unmute yourself?
Thank
There
you.
you go.
Mine is just a comment. So I'm totally sympathetic with David's approach and tech. I was thinking exactly in these days that well, medicine is not a nomothetic science; it's an idiothetic science, which means the science of the individual. And causation in medicine, I mean, every science tries to discretize the word, but causation is medicine, is especially dense and dynamic. What I mean by saying dense,
it's 18 hours.
Sorry, that's my clock. The point is that the pathophysiological processes going on in someone who's getting sick, they are the combination of many different physiological processes that go wrong in some way, in a cumulative way, and this combination is unique. Is unique in many senses, also because there might be backup mechanisms that intervene, but they don't work, et cetera, et cetera. So it's not only that causation is not deterministic, of course, it's not even statistic. It's dense, in the sense that Goodman meant dense. So I think that this kind of approach is at least the closest to what we can do best for the patient. That's my idea. Thank you.
So, Barbara, that's helpful. I mean, I don't think I disagree. I think the way in which causation is dense is already captured in the idea that causation depends on systems of structural equations. And you might think of those successive steps in the causal process as taking place through time, be very fine detailed, and you might a year earlier have the kind of condition that can lead through to the outcome of interest, provided everything works along the way. But you might have what did Nancy call them, derailers coming in, and what you find out is that the statistics will tell you how often the possible path from some putative cause to an effect is derailed, and how often it goes through. I mean, that's why going back to evidential pluralism, we want statistical evidence of the average effect as well as a mechanistic story, because you might have a plausible mechanistic story, but do you know before you do a statistical study how often it's actually going to run through that causal chain and how often will be derailed? So I take the kind of analysis I was giving to be able to accommodate, and in fact, depend in large part on the way causation is dense.
I also guidelines are make no sense.
Great. Okay, so we have 2 minutes and 2 questions. You can either fight between yourselves to ask the question. Do you want to ask a question first? Yeah? And if it's quick, Jimmy, you can ask a question, and if not, over a pint.
Thank you. I also I like structural equation models. They are very concrete and they're nice to think about, especially when they're linear and the causes are independent. And then and everything is fine until I think too hard about what errors are. And then I get very confused and I feel like I'm committing to some kind of statistical atomism where everything is composed of these independent statistical atoms I seem to have talked myself into a strongly strange metaphysical picture of the world if I write down these structural equation models. So can you help me? What is an error?
So nice question, and I don't feel very clear-minded about this. One thing, I stopped calling them error terms. Did I call them error terms in the talk? I mean, on the slides, I called them noise terms. And I'm thinking in analogy with statistical mechanics, the capital X's and Y's and so on are macroscopic observable variables. And then we have all the details of the microstate. And it so happens that we can get pretty reasonable predictions of some macro variables from other macro variables without knowing the values of the noise terms. But when we want to analyze what's really going on, we want to think the values of the noise terms fix whether you get the outcome. So that's the setup. Now, in a particular analysis, I would have birth control pills determined by just noise. But you might think, well, I could broaden the analysis and find some macroscopic variables there clearly are that will be good probabilistic predictors of birth control pills. So it's kind of relative to this sort of analysis that you can regard the causes of birth control pills as noise, but different analysis might partition those noise terms into further macroscopic variables. I mean, that's about as far as I thought this through. Is that
Yeah, me too.
So I think for the sake of time and everyone being quite exhausted, maybe we should wrap up there. Thanks very much, David.
And but when you finish tapping for me, I want to pause now and thank the organizers, thank Elsaline for being in charge of this, and Rivka for doing all the work. Thank you.